So we're going to start with what health economics is. You can go straight to the next one, please. And it's important to realize that economic evaluation is not about choosing the cheapest. Not always, anyway. Because like Ellen Maynard said, that the pursuit of efficient practice is not merely about reducing costs. If it were, the most efficient procedure would be to do nothing, as that pushes costs to zero. And we have done economic evaluations where actually the outcome was that if every smoker died from lung cancer quite quickly, that would be the most cost-effective option or the most cost-saving option. And that's not what we're about. Health economics is a study that attempts to allocate limited healthcare resources among unlimited wants and needs. And we want to achieve maximum health benefit for society. And that doesn't always mean we need to reduce costs. That means we are willing as a society to invest resources to get the most amount of benefit for the public and for society. So that's what health economics is about. Next slide, please. And it's all based on the concept of scarcity, because as we all know, there will never be enough resources to completely satisfy human desires. Because wants and desires and healthcare needs are unlimited. But our resources, and resources isn't just the budget, it's also human resources. It is financial, but it's also capital, environmental resources. They are all limited. So we have limited resources and we're facing unlimited needs, wants, and desires. And that's the issue. Continue, please. So the issue is not whether we need to prioritize, the issue is how. And the way we make choices is for the good of the patient, to improve efficiency and quality of care, to reduce waste, because if we are putting out interventions that are not cost effective and are not effective, we're wasting resources. And to address equity and equality, to avoid harm. And from a health economics perspective, we need to make choices because there is simply not enough. Next, please. And the root of all choice, if we had unlimited resources, you know, none of us needed to be here. We would just give everybody what they wanted. But choices, decisions, and prioritization need to be made because resources are scarce, and there will never be enough resources to satisfy all human needs, wants, and demands. And next, please. And the reason for this, there is an unmet need, and this unmet need is ever increasing. It's increasing because of the higher demand of an aging population, more comorbidities, more older people with increasing life expectancy, a decreasing health of the population, obesity, low activity levels, stress. So the age goes down, it goes up, the health goes down. We struggle with staffing levels, changes to budgets, ever more expensive technologies, and also increasing expectations. Next, please. And at the moment, obviously, COVID-19. And from a health economics perspective, the damage this has done is, you know, it's going to be years until we really see how this has affected entirely the healthcare system. And it's had an unbelievable effect on our resources, and we've all seen that, and it's put quite a sharp focus on the importance of health economics as well. Next, please. Because the main concept of health economics is opportunity cost. So if you take anything away from today, this is it. Opportunity cost means that when resources are limited, it is necessary to give up one thing in order to be able to acquire another thing. And that's not just a theoretical concept that economists have dreamed up. It's something we do in our head every day. If I go shopping and I don't have enough money in my pocket to buy everything I need to weigh up what am I getting and what am I leaving behind. And I do that by comparing the benefit and the cost of each item I want to buy. And then I put the item back that gives me the least benefit. And that's that's how we do opportunity cost, and we do it with our time. So for example, time is our most limited resource. And if I think in the evening, oh, should I read a book or should I watch the Great British Bake Off? I can't do both. I need to decide, and I decide subjectively what is of most benefit to me, what gives me the most utility. Utility being the benefit that is derived from consuming a resource. So that's opportunity cost, and we do that in our head every day without putting a name to it. It's just something we do, and it's especially important in healthcare. Next, please. Because everything we do has an opportunity cost because of the scarcity of our resources. So for example, and it's an older example, but it's a very good one. It's the opportunity cost of IVF, of in vitro fertilization. And if I give one couple in vitro fertilization, I can't afford 1/3 of a cochlear implant. And just imagine that poor person who only gets 2/3. One heart bypass operation I can't do, 11 cataract removals, 150 MMR vaccinations. And if I go outside the NHS sector, I can't afford half a junior teaching assistant for a year. I can't provide 2,000 school dinners. So wherever I allocate money to, I need to make sure it's the best use I can do with that money, because otherwise I'm taking that money away from something where there would be more benefit derived. Next, please. So health economics is about addressing the 3 E's, because good health is a necessary condition for a happy life. Good healthcare, which is accessed and used fairly, the first E, equity, and equally according to equal needs, equality, is often a necessary condition for good or better health. And the appropriate use of the available resources to maximize the health outcomes, efficiency, is required for good healthcare. Health economics is concerned with all 3 of this, but most of all nowadays about efficiency. We need to make sure that with the money, the budget, the resources that we have, we can provide the most benefit. And the most efficient system is the one where we can no longer increase the benefit we derive from any given mixture of resources by changing, what we're doing. We have the most efficient way of doing it. Next, please. And that's where health economics and health technology assessment come in. Next, please. Move on, thank you. So how do we make our choices? And the choices, as Kat said in the previous section already, we need evidence-based healthcare, which combines clinical expertise and judgment, the best available external evidence on clinical and cost effectiveness, which will then allow healthcare professionals, together with patients and other stakeholders, to reach the best decision in any particular situation. Next, please. So the main purpose of health technology assessment, of what we're doing here, is to inform policy decision-making, to promote delivery of safe, effective health policies that are patient-focused and seek to achieve best value. So health technology assessment is the bridge between the evidence, which floats around somewhere, and policy making. So it whittles all that evidence down with the overarching aim to present to decision makers a way to increase efficiency, equity, equality, and to get the best value in terms of outcomes and patient experiences. Because if I only have the same box of resources, if I have a lot of low value interventions in that box, overall, what I get out of it is much less than if I had the same box of resources, but a lot of high value interventions. I can provide much more benefit with that. And that's where we want to get. And appraising the clinical evidence and appraising the cost effectiveness evidence is really important to get that high value budget, high value box. Next, please. So the 4 key questions in health technology assessment: is the technology effective and safe? If it's not, why are we doing it? For whom does the technology work? Are there any subpopulations? What's the target population? And what costs are entailed in its use? Acquisition costs, administration costs, monitoring, other NHS resource use. And how does the technology compare to the available alternatives in terms of safety, efficacy, cost effectiveness? So those are the questions we want to have answered. And the health economic evaluation process helps us to do that. So it uses economic evaluation to compare alternative courses of actions in terms of both their costs and consequences. So we're not number crunchers. We're not, well, we are in a little way, but not mainly. We're not just concerned with how much does it cost. We're also concerned with how much does it cost compared to the outcome, to the benefit that I can get. So we want to provide high quality evidence on which to base decisions. And the aim of all of it is to improve efficiency and not forget about equity, equality, and quality of care. So it's a juggling act. Next, please. And the nature of an economic evaluation is very similar to the nature of a randomized controlled trial, for example, and we very often undertake health economic evaluations alongside randomized controlled trials, but increasingly also for routine, with routine data, or alongside real world scenarios where we collect data as the service is already being delivered. But we need a target patient group. We need an intervention and a comparator. So we're going back to the PICO. And we need outcomes. So we measure the impact on health status, and we measure the impact on healthcare costs. Health status could be survival, quality of life, and costs, we get to that in a moment, will include the intervention costs and all healthcare resource use that is associated with it. Next, please. And there are 5 main methods of health economic evaluation, but you will most likely only encounter cost minimization analysis, or predominantly encounter cost minimization analysis and cost utility analysis. So we're going to have a quick look at those next. Cost minimization analysis is quite simple, actually. It means if the outcomes from 2 interventions are identical, you choose the cheaper version, the cheaper option. Makes sense, because if you get identical outcomes, why would you pay more? So you choose the cheapest option. Now, that's the most simple way to do a health economic evaluation, but there are a few problems with that. Next, please. And the main problem being that it is really super unlikely that all outcomes of 2 different programs or comparators are identical. It may happen sometimes if you're looking at 2 identical medicines, for example, where one is generic and one's a brand, where you say, okay, it's the same thing. But most of the time, it's not the case. And when you find a cost minimization analysis where it's, where the company, for example, says, oh, this is now based on broadly similar outcomes, every health economist will, throw their arms into the air and say, oh my God, broadly similar does not mean identical. So a lot of the time, cost minimization analysis is not valid because the outcomes are not identical. So that's something to look out for. Is cost minimization appropriate? Next, please. But what we most likely will encounter is cost utility analysis. And cost utility analysis calculates the cost per quality adjusted life year gained. And I'm going to talk about that in a moment. So it's the cost per utility, per benefit that you get out of it. And cost utility analysis considers the impact of a policy intervention program upon an individual's and society's welfare. So we're looking at the costs, and then we're comparing it to the number of quality adjusted life years that we can gain. And the reason why we're doing cost utility analysis in most cases is because NICE has the £20,000 per QALY gained threshold, where it's easy to compare and say if it's below 20,000, sometimes 30,000, then we consider it cost effective. Whereas if it's above, we may not consider it cost effective. That's why we're doing cost utility analysis, because it's easy to kind of distinguish between is it cost effective or not. Next, please. So I've talked about the QALY, and you probably heard about the QALY a fair few times. So what is it actually? And the quality adjusted life year is a common currency that we use to assess the benefits and outcomes that we gain from a variety of interventions. And we obtain the quality weight from questionnaires such as an EQ 5D questionnaire, which has 5 levels, 5 questions, and you get a utility value out of it at the end. And the QALY combines in a single unit health-related quality of life and life expectancy. And quality of life is measured from 0 to 1, whereas 0 is death and 1 is, couldn't be better. There are quality of life values below 0, which are considered worse than death, like a chronic catatonic state or something like that, extreme pain. But we measure quality of life from 0 to 1 and life expectancy in years. Next, please. So what a QALY is if I live for 1 year at the quality of life of 1, I accumulated 1 quality adjusted life year. If I live at a quality of life of 0.5, say I've got chronic migraines, really severe migraines, and it affects my quality of life. It's only 0.5. And I live with that for a year, I accumulated 0.5 QALYs. If I live with that for 2 years, I again have 1 QALY. I hope that makes sense. So that's the QALY. And we calculate the cost per QALY. Next, please. So how do we get the costs now? Now that we have the QALYs, what costs do we need to consider? And in a health economic evaluation, there are always 2 components of costs to consider. First of all, it's the resource use that is related to the implementation of that new intervention. That could be new equipment, any training, any resource use associated with the delivery. For example, if it's rehabilitation, cardiac rehabilitation, we will need equipment, we will need a multidisciplinary team, we need staff time, they need training, we need maybe room rental. So that will all need to be included. If we look at the medication, we will need to take into account the acquisition cost of the medication. Is there any administration costs? Resources used for administration? Is there any monitoring costs? For example, does it need additional liver monitoring or kidney monitoring or something like that? So that needs to be taken into account. And then that's the implementation cost. We also need to take into account changes in healthcare resource use as a consequence of that intervention. Because if I have a very high implementation cost, it could be that it reduces hospitalizations, for example. So we would save money further down the line, save resources further down the line. And that needs to be taken into account. And that includes primary care, secondary care, social care. Next, please. So once we get the costs and we get the outcomes, we do the analysis, and we're comparing the old or existing intervention with the new intervention. And the result of that can be that the new intervention is more costly and less effective. So it costs us more, it gives us less benefit. We don't want that. We call that dominated. It's dominated by the old intervention. The old intervention is just better. It can be less costly and more effective. So we get more for less cost. We call that it's dominating the old intervention. So we want it, because it actually saves us money and gives us more effect. Then on occasion it can happen that it's less costly, but also less effective. And then it's kind of questionable whether we want to have it or not. It depends how much less effective it is and how much we can save. Most of the time we will find out that more benefit is purchased by investing more resources and more money. So the intervention will be more costly and more effective. And then, next please. And then we can, it's questionable as well, but we have our cost effectiveness threshold to guide us. And the result of a health economic evaluation is an ICER, an incremental cost effectiveness ratio. And that's simply the total cost of the new intervention minus the total cost of the old intervention. So what does the new intervention cost more? And the outcome of the new intervention minus the outcome of the old intervention, what more benefits does the new intervention give? And the higher the ICER of an intervention, the less cost effective the intervention is compared to the comparator, because we need to invest more money per outcome, per quality adjusted life year, if we're talking about cost utility analysis. Next, please. So this is how we kind of depict our outcomes. It's called a cost effectiveness plane. And on the top right corner, where it says questionable, that's where we often find ourselves. This is where the nutrient treatment costs more, but is also more effective. And the dotted line shows us the acceptable threshold. So that would be the £20,000 per QALY gained. And if it's below there, then we consider it cost effective. Next, please. In health economic evaluation, it's really important to address uncertainty, because health economics is not such a strict science. You know, we need to make assumptions. Patient pathways are really diverse. We need to kind of whittle it down to one average pathway, for example. And that's not always accurate for every patient. Unit costs that we're using are not always accurate or appropriate for any purpose. So it's really important to test those assumptions and those uncertainties with sensitivity analysis. So what we're doing is we're making plausible changes to our parameters. And then if the results are robust, those plausible changes will not affect the results to any significant degree. If the results are not robust, then those results will jump up and down. And then we need to have a look at, first of all, how likely those scenarios are in practice and where there may be a problem with the analysis. So sensitivity analysis is a really important part of health economic evaluation and a really important part of a good quality health economic evaluation. Next, please. So most importantly for you, I guess, is what do we do if there is limited evidence? Because there usually is. And we would, whatever evidence we have, we would critically assess in the same way as Kat just described earlier for the clinical evidence. We would look at the quality and the appropriateness of methods and the analysis undertaken, the quality, appropriateness, and relevance of the data inputs and assumptions. That's important in health economic evaluation because there will always be assumptions. Are those assumptions realistic? And how could they affect the results? The accuracy of the findings, including the appropriate account for uncertainty. Sensitivity analysis is really important. If there is none, then there is something fishy going on. And the quality of reporting. Next, please. And the consequences of getting that wrong is, you see, that the available evidence influences how we make decisions, how we allocate resources. And if we allocate resources to an intervention that's not cost effective, there is a chance of making the wrong decision. And that is even higher if we base it on poor or misleading evidence. And if we make the wrong decision, if we decide to implement something that is not cost effective, that is wasting resources, then we're reducing efficiency and we're potentially causing harm because we don't have those resources available to treat other people with options that would be more beneficial overall. And that's where our opportunity cost and scarcity comes in again. Next, please. So for us, the most likely scenario, unfortunately, for cost effectiveness is that you will read no relevant cost effectiveness analyses were identified in the literature search or repeat literature search. So what do we do then? Next, please. And the only thing I can tell you is just keep that health economic thinking in your head. Think about opportunity cost. Think about scarcity. Think about not wasting resources. And don't just think about budget, think about value. So for example, a high cost intervention that has little benefit is certainly of low value. But even if it's a low cost intervention and it still has little benefit, we're still wasting resources. Whereas a low cost intervention with big benefit is high value, which we want. But even if it's high cost and has big benefit, it can be a high value intervention. So if there is no cost effectiveness evidence, just focus on value, focus on opportunity cost, and don't just think about budget. Next, please. So that's me done. Thank you very much.